Hi, my name is Dr. Vasu Brown. I'm certified in wound care, and this is one of an interesting case we have been following for the past 5 months, and I wanted to present this patient. This patient had a venous ulcer, which originally she was admitted to the nursing home with a very painful calf wound, which measured 5 by 3 centimeters, and patient was initially managed with Medihoney, with Unabut strips and 3-layer compression wrap, and eventually the wound size improved to 2 by 3. And in November of last year, 2012, patient was discharged to her resident living place with a VNA to follow up with her wound management. But then when she went home, she became septic, was admitted to the local Metro West Medical Hospital, and there was told that she might have to undergo amputation. Patient refused and was readmitted to the nursing home, and I was called to go consult for the wound that patient has come back with, which happened on December 10th of 2012. And when I went in, the current wound measured 11 by 8 with signs of hematoma. We decided to go back to the original dressing, which was Medihoney with Unabut strips and a Curlux wrap, which we change only twice a week. And patient's wound stabilized. Her pain was improved, and then she was discharged from the facility. And I decided to follow the patient at her home. And the further slide, I'll discuss it, what happened. So on December, I think January 9th, patient was still at the nursing home. When I was following her, I found that she had signs of infection in her wound. The wound was smelling. So we discussed with the primary care physician at the nursing home, and she was placed on Levaquin 250 milligrams daily for 5 days. And the local treatment was changed from Medihoney to Zerofoam and Silvadine with, again, the 3-layer wrap, which involved Unabut strips, Webril, and a Curlux wrap, which we decided to change twice a week. And then patient condition improved, and patient decided to go home back to her assisted living facility. And she requested that I follow her at her assisted living facility because she was so scared that she would get sepsis again after she went home and she would have issues. So I agreed to do house calls for her, and we decided to follow along with the visiting nurses at her home. And the wound, the current picture showed when I was following that she was having another additional wound on top of her calf wound, which was previously there, which the original wound was measuring 11 by 8. On top, you could see like another wound was coming up, which looks like a new hematoma with a measurement of around 6 by 7 on top of the previous wound. So I decided whenever they have new wounds like this with hematoma, I always think of leaky vascular structure, like vascular membranes, like her vessel wall was leaking. It's because of reperfusion injury. When we sit down and we stand up, the extra blood that comes in, people with intact vessel wall are able to handle, but the extra blood that comes in, people who have leaky endothelium would start weeping these blood into the tissue, and that's why you could see like a huge area of hematoma. So the first thing we wanted to do was stop the bleeding that was going on, and also to manage her leg with compression wrap. The best dressing I found, which I like for acute bleeds, is Polymem Pink dressing. So I changed it to Polymem Pink dressing with a Curlux wrap. The advantage with Polymem Pink is you don't even need to clean the wound. It itself cleanses the wound. The idea behind is all the secretion has all the stuff it needs for the body to clean itself. So we just decided to watch how the wound was doing. And I will show you the follow-up pictures. And this was the same visit. You could see, like, also on anterior part of the shin, she's having same way bleeds. You could see, like, a little bit of hematoma, bruising under the skin. And the skin is falling apart. This is this indirect sign the patient is not producing the collagen and also the ability to repair her vessels. The factor that's missing is called EPC, endothelial progenitor cells, which actually expresses the protein that synthesizes the collagen. So the first thing I did was place the patient on methionine, 500 milligram POBID for 14 days, and we continued with the polymem pink dressing, which was on that the visit January 22nd, 2013. And then the wound measurement was stable at 11 by 8. And we continued the methionine in the visit of 29th, 2013, and I continued the polymem pink dressing. And I'll show you the next slide. This is the visit, the same visit on the 29th, which still shows that there is some amount of bleeding underneath, but you could see the skin is getting dry. It's not macerated, so the patient's fluid management on the tissue level, like, the maceration and lymphedema was improving. So on the February 4th visit, we found when we went back, the measurement was similar, except on the front part of the shin wound, which was only 1 by 1 and 2 by 1 last time. Suddenly you could see, like, lots of areas opening up. It was getting macerated, and the tissue, because of the fluid, the skin is breaking down further, and the polymem was holding the fluid in place, so the surrounding tissue was starting to break down. So we decided to use the xylem cellulose dressing to see whether we can cut down the skin breakage, and we applied to all the areas where it was opening currently, and we applied, and also patient was having smell in her, foul-smelling discharge, so we started polysporin powder to the wound, and then we continued with the polymem pink and a Curlex wrap. We continued this dressing until February 25th, 2013, and on February 25th, 2013, we changed the dressing to Silvadene and Dilantin 50 milligram to wound bed with polymem pink, because the idea was to recruit new blood vessels to see whether that would improve her healing ability. After adding Dilantin, you could see, like, the tissue is getting stronger. It's not as thin. The skin is getting thicker. You could see, like, new epithelial tissue coming in. Lots of new islands of skin were starting to form in the middle of the ulcer. So we decided to continue that dressing for another week. And when we went back on March 14th, we decided, like, since the wound still looked white around the edges, looks like it's still getting macerated, so I decided to change the polymem pink dressing to extra sorb dressing. The advantage with the extra sorb, it is little expensive dressing, like costs around like $15 per piece. But the advantage is it helps to control the metalloproteinases activity. So the tissue that is getting destroyed because of MMPs, they need cofactors, so that when you do the extra sorb dressing, it absorbs, or actually it doesn't allow all those cofactors to be available to the destructive proteinases and those enzymes. So the enzyme essentially becomes unable to continue their destruction. So when we changed the dressing, we saw a marked improvement, but you could see it was still not all right. So this on the next slide. So when we saw this wound on the 18th of March, you could see the wound maceration is better, but it had a very bad smell. It smelled like Pseudomonas. It has a very sweetish smell, like it smells like very, very sweet. And it had a greenish discharge. We decided to culture the wound. We sent it for culture, but meantime, whenever it looks a little shiny like this, I like to add antifungal cream to the wound bed. So I added antifungal cream. We continued the extra Sarb. We decided to keep it the same for one more week. So I told the VNA to continue the treatment, and we added polysporin powder to bring down the foul smell, and Silvadene, and with antifungal cream to the peri-wound area, like surrounding to the skin structures, so that we can improve it. And interestingly, when the lab called me with a culture report, they said it grew Pseudomonas, and also it had Staphylococcus aureus. So we decided to change the Silvadene to Bactroban, and we continued the extra Sarb, and we continued to manage this wound with the same Bactroban and extra Sarb for 2 weeks, I think. I think I changed the treatment after culture report came, which was around like 20th or 22nd, I think we changed it. And then I went back on April 8th, which is today. I'm recording this today, and I'll show you the last slide. This is multiple view of the same wound before changing to Bactroban. You could see like shiny discharge, and also, like, this is after we wiped the wound clean. We washed the wound. We were applying antifungal cream to the peri-wound area. This is again another view of the leg. This is after the wound was cleaned, and after we applied the antifungal cream to the or the surface, the skin surface. We are trying to put a new dressing on, and I forgot to mention extra Sorb is a foam dressing. After 2 weeks of treatment with Bactroban, you could see a marked improvement. The tissue has completely filled in, and there is like very, very little wound left, and the wound looks excellent today. And I applied a new Dermafill dressing, and I'll show you in the next slide. This is the calf wound. You could see like it is only now like 3 by 2 centimeters. It's very, very small. It's all filled in. And I'm going to show you the next slide. So I applied the Dermafill dressing. I love Dermafill. It's a xylem cellulose dressing. It's the first bacterial xylem cellulose dressing. It works like a second skin. So you could see like it has got a little crinkle on top of the wound. If you pay attention closely, you could see like it's lifting off. It looks like almost like a plastic paper. The advantage with Dermafill is it works by sealing off the wound completely, by creating a seal, so the wound can start healing from inside. So essentially it seals off the wound, and there is no need to change this dressing. It sometimes develops holes in the middle because body has used up that Dermafill, so you just plug it in again. And I will show another view of the same. This is the anterior part of the wound. The previous one was the calf wound. This is the shin wound. And you could see like I applied another Dermafill on top. And you could see almost like all the skin has come back, and it sealed itself. So a tremendous improvement from like when we originally started following the wound in her home, which was a resident living facility in Framingham, and to the current the wound. And she is very, very happy, the patient. And I'm assuming like in another 2 weeks I'll be discharging her from my care. But I just wanted to show the impressive healing